I'd just like to take a minute to tell you a few things about us. Ontario Neurotrauma Foundation is a health research organization that focuses on the practical application of research. I hope my voice isn't coming across twice. Our work aims to advance, gather, and apply research knowledge to improve systems of care, outcomes, and quality of life for people with brain and spinal cord injuries, and to increase the effectiveness and use of prevention. ONF works with partners and stakeholder groups in Ontario, across the country, and internationally. The Foundation prides itself on its relationships and ability to initiate activity and network with experts and organizations in neurotrauma and in related fields. ONF receives its funding from the Government of Ontario and has existed since 1998. We always say that we have provincial focus but national reach. In the area of acquired brain injury, we are proud to be the go-to organization for research knowledge and guideline development in Ontario and far beyond. Our speakers today are both specialists in physical medicine and rehabilitation, with significant expertise in the rehabilitation of people with brain injury. Dr. Mark Bayley is Medical Director and Clinician Scientist at the Brain and Spinal Cord Rehab Program of Toronto Rehabilitation Institute as part of the UHN, the University Health Network. Dr. Shawn Marshall is the Medical Director and a Clinical Investigator for Acquired Brain Injury Rehabilitation at the Ottawa Hospital Rehabilitation Center and the Ottawa Hospital. Aside from being clinician scientists, Dr. Bayley and Dr. Marshall have extensive experience with systematic reviews of literature, both being leaders in the ARABI, or the ABI evidence-based reviews, and the development and implementation of clinical practice guidelines in areas of ABI, and Dr. Bayley in stroke as well. Dr. Bayley is the chair of ONF's ABI committee, and Dr. Marshall served as the previous chair. Their leadership roles for ONF and for the province in linking brain injury research to practice in practical and feasible ways cannot be understated. They have led the development of the ABACUS, stands for ABI Knowledge Utilization Strategy, and the guidelines for concussion, MTBI, and persistent symptoms for adults, both the first and second editions. I am pleased to introduce them in the context of the INESSS-ONF Clinical Practice Guideline for the rehabilitation of adults with moderate to severe TBI. The INESSS-ONF Guideline is a truly cross-provincial initiative, and our partnership with INESSS in Quebec has been very collaborative, strong, and fruitful. For those of you who speak French, INESSS stands for Institut National d'Excellence en Santé et en Services Sociaux. Working with both INESSS and ONF, Drs. Bayley and Marshall are the Ontario leads, bringing their clinical expertise and expertise in guideline development. I know they will describe the team in a little bit more detail, so without further delay, I will pass this over to them for the presentation, Dr. Bayley and Dr. Marshall.
Thank you, Corinne. I'm assuming everybody can hear me. We want to welcome everybody. And basically, we're doing representing the work of a large team of people and collaborators. I'm going to see if I can advance the slides for you. On our development team, Corinne Kagan, who you just heard from, is our representative from the Ontario Neurotrauma Foundation. Catherine Shawn is our leader from the INESSS organization. We're very pleased to work with researchers Bonnie Swain, who's extensive experience in traumatic brain injury, who works at the University of Montreal and is affiliated with the Career Research Center. Marie-Ève Lamontigne, who's at the University of Laval in the CIRRUS Research Center. And basically, we would not be able to do this work without our coordinators, Eileen Kua and Anne-Sophie. Sorry, I'm just trying to make sure you're looking at the right slide. So the aim of our presentation today is really to introduce you to how the guidelines are being developed, and really this is an opportunity for feedback. So if we go to the next slide, our objectives, specific objectives today are to, I'm not sure what you're seeing, I'm seeing the presentation move. So at any rate, is to provide an update regarding the guideline development process. And we hope that by the end of this presentation, you should be able to name the priority elements of the, put my video on. You should be able to name the priority elements of the guidelines. You also should be able to discuss and evaluate the strengths and weaknesses of previously published guidelines. And you should be able to name the topics that we covered. And we'd really like that if we have an opportunity in the next hour or so, that you could provide us feedback as a project team about the optimal method that we can present the guidelines to make them usable, and also the optimal methods for implementing them in the clinic. If we go to the next slide.
Mark, if you could just move your phone a little closer, to your mouse.
We're losing it here. Sorry, I'm having trouble. What is the evidence? So it really speaks to us as far as what is evidence-based practice. And what we realize in evidence-based practice is that there's thousands of articles coming out every year, and that it's hard for us to do what we say we want to do, which is provide evidence-based practice. So why the guidelines needed is that we really want to provide guidance to people who are struggling to keep up, and we really want to understand who are going to be the users. So just to remind you that evidence-based practice is the conscientious, explicit, and judicious use of the current best practice evidence in making decisions about the care of individuals. And clinicians really want to use this, must find trusted sources, and so we hope that we will be a trusted source for this. We can go to the next slide. Sure, David's going to help me. So what are clinical practice guidelines? This is the dry stuff. Clinical practice guidelines are systematically developed statements based on best available evidence to assist practitioners and as well patients about appropriate health care for specific clinical practice circumstances.
Mark, can you speak louder?
Sure. I'm just going to, they're generated from a systematic and rigorous explicit methodology, including review of all of the available scientific literature under study. I'm just going to, just one second. Sorry about the background there. So just to remind people that when we do guidelines, we are combining not only scientific evidence, and I'm going to talk a bit about that in a moment, and what the levels of scientific evidence are. We have to include in this clinical expertise, and we must also consider the opinions of patients and their preferences. And that's what makes clinical practice guidelines the most important part of evidence-based practice, in my not-so-humble opinion. If we can go on to the next slide. I'm not sure. I'm just going to move it slowly. So, what guidelines can do is they can identify the nature, volume, and quality of research evidence supporting the clinical recommendations. They can help people improve decision-making, and ultimately our goal is to improve clinical outcomes. They can. One of the things that's really considered poor in healthcare is the consistency of care, and variability in care is not good. And so we really want to increase the consistency of care. If we increase consistency of care, this is a point that a lot of people don't always think about guidelines. Even if there's not lots of evidence, if we standardize care and then evaluate it, we've offered the field an advantage, because then we can evaluate whether best practice care actually works. So many people in the field are saying standardize and evaluate. So it also can help in many cases inform patients and other stakeholders regarding the treatment that they should be receiving. And we often feel that, and you'll see as I speak later about the influencing of health policy and influencing those who make the decisions about healthcare, are often important as well. So we're going to talk about the guideline development process. We started with asking a clinical question, and we really ask a clinical question that is what are the current best practices for stroke rehabilitation across the continuum. And so we're going to go walk you through a little bit about this in terms of how is evidence turned into practice. And we use what's called the ADAPT cycle, which is available at www.adapt.org. And basically that cycle involves not reinventing the wheel, but rather looking at what is already published and making sure that we do that, do due diligence in reviewing what's already been published and making sure we don't reinvent the wheel. So we start with a problem, and usually we ask a clinical question, which is a PICO type of question, which stands for what kind of patient or population are we talking about? What's the problem they have? What's the intervention that we want to do, and what does it result in? When we do that intervention, what are the outcomes, and how do we compare that to usual care, usually, or other types of opportunities? We go to the next slide. I'm going to just remind you, I mentioned this a moment ago, but I'm going to remind you again that there's a hierarchy of evidence. And the hierarchy of evidence begins with the basic stuff like setting out to be, to standardize your care, such as a care map. And then getting together with a group of other people who are in the field and developing a consensus as to what it's better level evidence than just individual practice. Then we start to look at descriptive studies where people describe a problem and what happens to it. A higher level evidence than that is a before or after study where we look at somebody before treatment or after treatment. And that's a case series, or it may be an individual case. Getting better, we then start to compare individuals to themselves or to other people who get a similar treatment, and that's a cohort study. One of the problems with cohort studies is that they result in the possibility of bias. So because we might have, the person who assigned people to different groups may have inadvertently put all the good candidates into one side of the study so as to get better outcomes, or vice versa. And so a randomized controlled trial is a higher level of evidence because you randomly allocate people to the different levels, different treatments, and you reduce biases that you might not have been aware of. When you do a meta-analysis, you actually combine randomized controlled trials, and that means that you've got not just one randomized controlled trial, but multiple. And then, of course, a systematic review means that you're reviewing everything. But a systematic review doesn't really provide you with the final word. It really tells you that the level of evidence. And really, this is where clinical practice guidelines come in, is they provide you with guidance based on experts and their thinking about this. And so I think that you really should be aware that we're not doing a systematic review only. We've done a systematic review to prepare for these guidelines, but we're also doing the guidelines to help you understand what you're going to do. So if we go to the next slide, I'm just going to move it. So here's the problem, which one of my favorite quotes, all breakthrough and no follow through. So this is where a lot of money has been invested, $100 billion a year worldwide investment in health research are not optimally achieved because of translating the knowledge into practice. It's estimated that it may take 17 years to put in practice what is published today. So, and even then, of that, only 30% of what is published is actually in practice. So we are being using the knowledge to action cycle, and this is from Ian Graham, who's a Canadian who's led the way in this. And this cycle, in the middle, just quickly orienting, is the knowledge creation part of the funnel, and we are doing the part where we're synthesizing knowledge and building knowledge tools, which we call clinical practice guidelines, which can then be adapted to the local context, tailored to the local needs, and then we can evaluate the outcomes. So without further ado, I'm just going to tell us, here's an example of our knowledge translation problem. As I told you, that only a small percentage after 17 years. And even when we did our own survey of users, asking them, do they know at least one practice guideline that supports the use, then we found that a large percentage didn't. So now, in part of our interactive part, I think I'm going to go ahead and do that. We want to take a poll. So we want you to answer on your screen. You'll see in your lower right corner of the Adobe Connect platform that there are 3 questions. And we'd like you to answer, where do you think you will want to use the guidelines? At home to catch up with the evidence, at the bedside near the patient, or at my workstation before seeing the patient. This will help us in deciding how to do this. Thanks very much. We'll give you a second to vote. We still know some of you are out there.
Mark, can you hear me?
Sorry?
Can you hear me?
So yeah.
Can you try to speak directly into your phone? And also, I'll advance the slides
Yeah.
for you because they're buttons on the bottom left, so it's not a drag thing.
Yeah, okay. Okay. So if it looks like we have a fairly solid consensus that people are going to use these guidelines at their workstation before seeing a patient, which is really helpful for us because we know that you're only going to have a few minutes and we'll need to work on the navigation of the guidelines. If we can go to the next slide, David, just so we don't, that would be great. So I'm going to hand off to Dr. Marshall now, who's going to talk a bit about some of the things we learned from developing the guidelines. Dr. Marshall?
Hi, I hope that everyone can hear me. I should be in, so thanks, Mark. I think I get to enter into the interesting part. So we're treating this guideline, we aren't presenting you the full guideline today. This is like the trailer that we're kind of giving you the background on it, kind of what we found to date and where we're going with things. So I think what we expressed is, and I think even leading into that question we just answered with Mark, and he showed as an example, is that guidelines are great. We can all agree on that. And the real problem is implementing them, using them. What you need to do is, first thing you need to do is guarantee that they're up to date. So we identified that there's a need for adapted clinical practice guidelines for brain injury, moderate to severe. There is expertise in Ontario and Quebec. In fact, that's where we used our experts from. And we really decided to move ahead on a new process, to start a new adaptation process for guidelines. We'd done this a number of years ago. A number of us were involved with the guidelines, the advocates that were developed back in 2007, and things have changed. So the project. The partnership was with the Institut National d'Excellence en Santé et en Services Sociaux, INESSS, and Ontario Neurotrauma Foundation. And we wanted to do a joint production of a clinical practice guideline intended for clinicians and administrators delivering rehabilitation services to adults having sustained a moderate to severe TBI across the continuum. And I think the evidence has changed. And I think this joint expertise, because we know that brain injury and all healthcare services are managed across provinces, adds to generalizability of these guidelines. So I think that's where we started, and it's been a great collaboration. Now, here's the steps of the project, and what I'm going to describe to you is what we've done and where we are to date and what's coming. And then Mark's going to finish up at the end of the presentation, getting some feedback and kind of giving a sense of what really is going to be presented to us in the very near future. So the first thing one starts with is you want to find out what information is out there. And I think one of the beauties of the ADAPT cycle is that it doesn't want you to reinvent the wheel. If people have done good work, great. Let's use their good work like we should. Like any clinicians, we're great at observing things. So the first thing we had done with this project was did a comprehensive scoping review, kind of a quality evaluation. And this is obviously a very busy slide. What it's supposed to show you is that we tried to look at it from many different perspectives, everything from the acute inpatient following moderate severe traumatic brain injury all the way out into the community. And these resources that are tailored along the left-hand side of the screen in the most left-hand column are indicating, okay, these are the resources that we identified, and these squares are identifying the topics that are covered within that. Now, what we did was we went through this and we identified ultimately 9 guidelines on which we could base our findings. So we found 514 documents, we went through that, and then we actually came down to ultimately distilling it down to 9 documents. They had to focus on moderate severe traumatic brain injury, they had to be guideline based, and they had to be related to rehabilitation intervention, because those are the things that we're focusing on. And right here now is where I'm going to come up and we're going to talk about the AGREE methodology. So my question to you, even before going into this and talking about this, is poll number 1. And I ask this all the time, who has even ever heard of the AGREE tool? So so far we've got 100%, we're going for better. We weren't going for better, you can't do better than 100%. And we're seeing who's even heard about it. Okay. So we're waiting for the numbers to come in, and just like early polls of an election, I appreciate anyone else can put this in because this is meaningful to us in our presentations in the future. And what this is telling us is that 73% of people have never heard of the AGREE tool, and but then obviously about 27% have. Great, that's good to know. The AGREE tool is a tool to be able to use to evaluate guidelines. And we're going to show you a good example of why guidelines need to be evaluated. Because we often read what's in front of us. If someone says there's a guideline, as Mark already indicated to you in the hierarchy of information, in what we want to use that's reliable, guidelines are at the top. Clinical practice guidelines are up there. But as you can imagine, we've created guidelines here that we're going to talk about today. I've already told you we found 9 other guidelines that are relevant to the topic we're looking at, and we want to know about the quality. And just like anything else, you want to use what's best, and you need a way to be able to at least assess that. If you're looking for hypertension guidelines on how to best treat hypertension, do you go to the Canadian Society? Do you go to the American Society, the British Society? Hypertension is the same across all countries, I presume. So you're really looking for best practices, best guidance. And this AGREE tool looks at the way that the guideline was created, and can you trust that guideline? And that's important, because if you want to change practice, you have to be convinced that people have gone out of their way. So if I'm going to change what I do, I want to know for sure that this is going to be meaningful to me and useful to me. Am I doing the right thing? So the AGREE methodology, we've done a scoping review. We use the AGREE tool to evaluate the instruments, and independently evaluated by 4 appraisers. So we had people individually look at this. I'm going to show you the results of that in just a second. And the other point I want to make sure is not all guidelines are created equal. And one of our jobs today is to convince you that we've done a good job of creating our guideline that we're all going to use together. Now this is a list of the 9 guidelines that we found. Some of them, as you can tell right now. So for instance, they go back as far as 2006. Beyond that time frame, you're probably getting to the point where they're fairly outdated because we're going back 8 years, and things, technology, even guidelines, the way they have been developed have changed. And these guidelines, as you can immediately see, some are very specific. So for instance, the second row down, the New Zealand Guidelines Group is a kind of a broader evaluation. And then for other groups, they're kind of very specific. So for instance, the INCOG group guidelines are very well done, as I'll show you, but they're focusing on cognitive rehabilitation, not across the whole spectrum of brain injury. So we're using this because part of our guideline approach is to use a broad approach, as you'll see, to our topics that we've decided to cover. So here, there are multiple domains in the AGREE tool, and this is just showing you how they come across. Have they defined scope and purpose? And in this instance, you can see those that were in red, none in this green yet, are not as well or consistently done, and some of those that are in green are well done. Now, stakeholder involvement, very important, particularly when you're talking about across the spectrum of rehabilitation. So this is going to be important as to, how are the guidelines developed and who is involved. So you can see that stakeholder involvement was in the, in some instances really not involved. Other stakeholders weren't well identified at all, and some well done. You'll notice the ones on the left-hand margin, particularly the SIGN, S-I-G-N, and NZ, New Zealand guidelines. They are typically classically well done because they're done by guideline development groups. So huge advantages to people who do this regularly. Rigor of development. If we have to hang our hats on one element of the agree-to tool that most people would be confident about is how thorough were these guidelines done. And as you can see in this, there's a variability in the quality and the rigor of development of guidelines. This is something that you want to really look for if you had to hang your hat on one element. Clarity of the presentation, again, this is important to you as frontline users. You're wanting to use these guidelines at the workstation is what we voted on. That means you want them easily adaptable. Us handing you a 300-page, 3-inch thick guideline and say, go for it, isn't going to help you. You want it to be accessible, you want it to be clear, and you want to be able to interpret the recommendation, and you don't want it to be kind of a motherhood statement. You want it to be specific. So these are important elements of it too. Next, applicability. So again, in this guideline recommendation, and this is obviously where many guidelines are falling down, is how can you take that guideline recommendation and apply it directly to the clinical situation. That does tend to be a weakness, and in the most recent, who a number of us have worked with, in the INCOG guidelines, and for instance, I think you can see that it's approaching better use because the guideline recommendations are being made more practical. And then editorial independence, it's important to know, even more important, for example, hypertension guidelines, that there's independence, meaning that they haven't been unduly influenced by industry, for example, or the pharmaceutical industry. And in many instances, certainly in the groups that design them, you need to declare what are the conflicts of interest that have been involved. And the mean guideline rating, so overall, how good are they? You can get a sense that some are better than others. Okay, so the next part of our project, even before we started this project, is we did a survey of the end user's needs and expectations. So we'd set the ground, we looked at this idea that, okay, we're going to move ahead with a guideline, we've identified what we want, what are we looking for at the end? What's the end result going to be? And well, we have a captive audience. We have people who work within traumatic brain injury rehabilitation throughout both provinces of Ontario and Quebec. So we did a end user survey. And so essentially we looked at stakeholder involvement. I'm just going to go back a slide. Yeah, we looked at stakeholder involvement, and we looked at who would be involved. So this is the process that's monitoring it overall. So the overarching project here, and as you can see, there's needs are informed by 477 rehabilitation clinicians. And then later on, we're going to be dealing with implementation. So we did an electronic survey based on CFIR model and the analysis of existing clinical practice guidelines. We surveyed clinicians, coordinators, and managers. We did it across the spectrum of acute care, rehabilitation institutions with inpatient and outpatient units. We did it in Quebec and Ontario, and we gave 1 month for this survey to be completed. And as many of you, I presume, who are on this presentation today were involved. So essentially, as you know, those of you who are involved, there was 4 sections in the survey, so we tried to get a profile of the respondents, knowledge and perception of existing clinical practice guidelines, and contents and format of clinical practice guidelines, how you'd want that, and your thoughts on the implementation process. So these are the things that we had targeted. Not everyone was eligible for this. You actually had to work with traumatic brain injury survivors and be able to continue on with the survey, otherwise you were kicked out. And from there, we got responses. This is what it looked like. In all, we had 487 individuals respond. We don't know the full percentage because we did this approach through clinical managers in different programs. So we do know is that of those who did respond, 95% were able to continue on with the full survey. Fairly equal distribution between Ontario and Quebec. I guess given our relative sizes, Quebec fared a bit better. And then male to female, I think these ratios are not surprising. We're very pleased that we had representation across the acute hospital care settings, rehabilitation institution settings, and those with inpatient units and within and outpatient units. So we also had management involved, clinical coordinators, and clinical physicians were the emphasis, and that included physicians. So I think the key thing here is we felt we had good input across multiple stakeholders and domains for this. A large proportion of the respondents were not aware of any clinical practice guidelines for rehabilitation of adults with moderate severe traumatic brain injury. I think that's an opportunity for us. First of all, it's good to know that people aren't aware. That's why I think Mark felt it was important, and I felt it was important for you to get some background on what is the utility of a clinical practice guideline. Many of us in our practice, if we're a bit more mature, such as myself, clinical practice guidelines didn't really exist back a number of years ago, and they're now come to the fore, and the science is always changing. Identification of relevant topics were identified, comments and suggestions regarding new elements, for instance, elderly patients, were brought forth, and then ideas about the implementation process were also introduced. Okay, so 47% of participants knew about at least one TBI guideline, but they knew about it, but they found that they weren't using them. And I think that's key. Again, how are we going to have people use them? Guidelines are pretty. They're wonderful. They're nice to know they're there. Do you use them? And participants have positive opinions about them, but again, we have to look at the implementation process about how we're going to move this forward. Now, information we learned, stakeholder consultation, guideline topics. So the things that caught people's eyes, and you can see by the percentages on this graph right here, questions about duration of interventions. How long do we do therapies for? How long is ideal for admissions? Intensity, frequency of interventions. On your inpatient and outpatient services, how frequently and how intense should the interventions be? We probably all have sensitive ideas about this, but what is everyone doing across different institutions, and what's the evidence say? Rehabilitation models or reference frameworks. So for instance, how do these work? So I think people were asking questions about that. Here within the early recovery, the questions that came up at the highest were cognitive function impairments, direction about that, direction about behavior disorders and how to manage and intervene with those, management of fatigue and sleep disorders, and mental health, psychological and emotional conditions within the brain injury setting. So again, these are just highlighting areas that might be prioritized when we look at implementation strategies. Again, stakeholder consultation, looking further. When you get into community, caregiver supports. What's the best practices for caregiver supports? What should be offered given limited funds? Skill and maintenance and quality of life. So again, looking at what the evidence says and can give direction for that. Activities of daily living focus, and then really, I think a very important one is return to work, school, and productivity following brain injury. So again, this gives us direction that when we're crafting the guideline, trying to come up with tools, and trying to make prioritized decisions about resources and materials, these are the ones we're probably going to start with because these are the winners. Assessing barriers to knowledge and use. I think that Mark's highlighted this, and we have to look at what's going to help our guidelines move forward. And I think that's critical because there can be lots of great information, but this is the one important gap. So stakeholder consultation, what helps people? Well, the facilitators. We can talk about barriers, that's kind of negative. I think we should talk about facilitators. Formal training. So how do you use a guideline? We're just touching tip of the iceberg today in relation to the idea of, what is a guideline? How does one use it? How can it be helpful? Availability. Does it come in paper copy or electronic copy or both? And team use of the clinical practice guidelines. How do you get teams to use them? For instance, are we all on the same page? We talk about interdisciplinary. Are we all following it together? The presence of tools. So again, if the resources are at hand, I think many of us know from using a guideline, if it mentions that tool, frankly, you want that tool in your hand. I don't want to have to go look it up on Google, go print it out. I want to have it accessible and ready to use. I think that's what many people tell us. And they want to know how to use them correctly and what do they mean and what's the added value. Active training. So how do we get across using guidelines? What are the best examples? For example, case histories came up with 71% of people. giving good explanation to how the guidelines might be implemented or used. Workshops. So workshops are interactive. And then just discussions about the guidelines themselves. So again, some good direction for us on how they might be used in the future. Synthesis of existing information, that's what we've done. We went through the 9 guidelines, we looked at the quality of those guidelines, and we synthesized and grouped together the different recommendations for us to review within a guideline expert consensus meeting. And that's where we went next. In November of 2014, many of us were lucky enough to get convened in Montreal to have an expert consensus conference. And what we're able to do is work through the synthesized information, and I can only tell you what a great team we've been working with who synthesized a great deal of information for us to come together and at least start looking at what guideline recommendations should move forward in the process. So we convened 60 experts, Montreal, November 27th and 28th, 2014, 2 very exciting but very tiring days. I think everyone worked very hard. We formulated recommendations from the scientific evidence. We formulated recommendations not from the scientific evidence that were important to be answered because they were very relevant they're very relevant to the practice of brain injury rehabilitation. And we tried to also look at indicators. How are we going to know that our guidelines are making an impact? How are we going to know that things are being used, picked up, and benefiting patients? So those are some of the things that we were looking at within that as we developed this process. Where are we at in the project? It's moving along well, and that's what I'll say about that. I can say that we wish that we were completely on time, but as you can see right now, we've accomplished much from the beginning, from steps 1, 2, 3, and 4, top left-hand corners of the boxes, and we're down here to the last part. We are hoping to have the guideline introduced by spring, May of 2015, but our target now is the fall of 2015, and as Mark will update you, we're on a good progress to that end, and I think that we'll be happy with where those results go. I'm happy to take questions after along with Mark, but I'm going to move it on to Mark to kind of finish up with the final part of the presentation.
Thanks, Shawn. Just going to make sure that you can hear me okay. I'm going to try a different way this time. So good. It sounds like we're okay. My final bit is just to what you're going to expect, a little bit of a teaser. So we have divided the guidelines into 2 main sections. The first section is known as components of the optimal TBI rehabilitation system. We realized that there was a need to provide guidance to stakeholders that are payers or policymakers, and really the components of the optimal TBI rehabilitation system are designed for managers and leaders in the system, as well as for clinicians, but most importantly, to think about if you're going to set up a rehab system, what are the components you need to have? And I'm going to talk about that in a moment. And the second section we realized was that people would want to know, well, how do I take care of fatigue or cognitive difficulties? And so we have a second section which is organized as assessment and rehabilitation of specific brain injury impairments. So just to give you a breakdown of what's covered under the components, we provide guidance as far as general principles of organizing rehab services, and that's sort of around the the membership of the team and things like that. We talk very strongly about the importance of specialized health professional training and how managers and people need to be aware that this is a specialized area and that people need to be trained not only in brain injury but also some of the risks in behavior and agitation. And so there's a section also on risk management as well in the guidelines. We also have some comments about case management and the importance of having a unique person who follows things through, and that's evidence-based. And then we start to break it down into the various sectors of the continuum. And the first sector is what should you do when a person has altered level of consciousness? What are the expected rehabilitation services? How should the transfer to rehab go from acute care? We then move into models of traumatic brain injury inpatient rehab, and that provides guidance around the team members and different models of care. A big topic, as you heard from Shawn, was the importance of intensity of therapy. And just a little teaser, the evidence is still emerging as far as what the most appropriate intensity. But what we found when we've done our review, and some of you may have attended the webinar by Dr. Green, is it emphasizes the importance of involving people in challenging activities cognitively as well as physically in the early inpatient stages. And some of our data comes from the practice-based evidence study as well as from the intensification study that was spoken about a couple weeks ago by Dr. Green, which really suggests that we really probably should be paying more attention to cognition, cognitive communication, and challenging people with effortful activities. There isn't really guidance that we all want about the number of minutes of therapy that are ideal, but clearly we're still feeling that a minimum of 3 hours seems to be reasonable. It's reasonable in the stroke, and so we're probably going to be coming in with some recommendations along that way. As far as we provide guidance about discharge to the community, and we also are providing guidance about models of community rehabilitation. Unfortunately, there's not as much evidence in this area, and so we try and provide some guidance that we can within the level of the evidence in our consensus process. We also have provided guidance about leisure and recreation, driving, and vocational rehab, which was highlighted by our stakeholders. And we didn't want to forget about the importance of caregivers and family and just brain injury education for the population. So that's what we should build and put in place for an ideal system. And we also cover many of the topics you saw in Shawn's review in specific sequelae. So the important components of a comprehensive assessment, the assessment and rehabilitation for cognition, cognitive communication, swallowing, motor function, sensory function. We heard about fatigue and sleep being important, and of course psychosocial and adaptation and neurobehavioral and emotional mental health issues were highlighted by our stakeholders as important areas to provide guidance and tools. And we're also dealing with the special challenges such as concomitant substance use and other mental health diagnoses and some of the other special challenges. So we're going to go to a poll now, I think, David, are we? And we'll back to our poll. Hopefully we can get you out of your sleepy somnolence as lunch goes down and ask you a question. So what strategies do you think would be help most with us implementing at your site? And the choices are education of your managers, audit of your current practice to provide you with feedback, local meeting with colleagues, a Ministry of Health mandate that you must meet the standards, like a quality-based procedures, and we'd love to hear from you as to what you think we should be focusing on or how you think these might be helpful. This is a little more challenging question because there is no right answer. I think we've got a good number of surveys in, and thanks very much for participating. A lot of you felt that there would be a nice value in auditing your current practice and also getting the support of a Ministry of Health sort of policy, and that's very helpful and allows us to focus our energies appropriately. Just wanted to talk a bit about how we're going to evaluate the impact of the guidelines. We are providing in the guidelines two kinds of measures. So some people have had some struggles with this, so I'm going to call them process indicators or process measures. So process indicators are indicators that the guideline was followed, that people were provided with the right assessments, that the actual evidence-based practice occurred. So in the case of perhaps leisure, you might think about the percentage of people who actually had a leisure assessment and a leisure therapy. That would be a process indicator. An outcome measure, on the other hand, is really a measure of the impact on an individual patient, a group of patients, or a population. And we're going to provide guidance in terms of the ICF framework of body structure, function, and participation of some measures that might be useful to. So, for example, in the instance of leisure, you could look at life habits, the Life H, or you could, in patient, you could look at some other measures of function and disability that you can use. And so the guidelines will have paired with them not only the process measures, but also the outcome measures, and that will provide you with how to audit your practice, as well as what the outcomes you expect your patient will get. I also want to highlight in the guidelines that we're just in the process, really, of finalizing the guidelines, as Shawn alluded to, but more importantly, we realize that there's probably a lifetime of work for all of us to implement this guideline, what we have, and we have over 100 recommendations. So right now, our expert panel is engaged in a process of voting, which highlights those recommendations that will be prioritized. And so that will allow us to present the priority guidelines in a sort of optimal way to sort of allow you easy things of what everybody thinks is the most important things to do. So in presentation and developing the website, we really want to provide you with not only the guidelines, but other tools. And so part of the problem is that if we were to present the guidelines and try and go through and develop tools for every single recommendation, we'd have challenges. So what we're going to aim to do is to have decision algorithms, standardized assessment tools that you can download from PDF, so that when you go to use the guideline, that there will be tools attached to all the priority recommendations that have been voted by our team. And so that's why we're perhaps a little bit behind, and also why we want to make sure that we get it right. We also, obviously benefit from your insights about when you're going to use this. At this point in time, I'm going to open it up to questions. I believe that you can ask questions by typing in questions using the chat line, because we are in presentation mode, and I don't believe that all the participants are able to talk, but I'll leave it to David. Do you want to add anything?
No, guys, just write your questions inside the chat box where I just posted, and I'll read it out to the presenters.
So just while we're waiting for some of those questions to come in, I'm going to just talk a little bit about the goal for this. Is that I think our goal is to really have the most up-to-date guideline in brain injury. And we in Ontario are in a little bit different position than Quebec, where they do have accreditation. Although we're hoping that, as many of you advocated for the Ministry of Health to kind of mandate the standards, we will hope that we can link with our folks at the Ministry. We're working with Thomas Custers, who's in the evaluation portfolio and performance appraisal in the Ministry, and work with them to sort of figure out what's the ideal method of doing this.
Allison Banks,
our first question is, when do we think the guidelines will be available? Well, we're really working hard right now to get the prioritization done. Our hope is fall of 2015, and for those of you who are online, we are in the process. We'd love you to email us or whatever, or email David and just say you're interested, so that we will, I'm sure you're already on our distribution list, so as soon as they're put up, we will let you know.
I think, and like previous guidelines posted through the ONF, our anticipation is that they'll be freely accessible through website and probably a PDF form to begin.
So, seems that some of you have a question, you're typing, so, oh, there's some more typing, that's good. So we're expecting a couple other questions. I guess while we're waiting, we really appreciate your feedback. And if you have any feedback about any of the content today, please send it to David at ONF. We do value it. Although we did survey a large number of people, we recognize that we may not have reached all of you. So just going to wait a few more minutes, a couple more minutes. I know I can see some people are typing. It looks like Justine Barron came in with, are you planning to conduct a barriers facilitators assessment as recommended by the Knowledge to Action Framework once the CPGs are out, and to improve uptake? Thanks for that, Justine. Part of what we did when we did the survey of end users was identify the barriers or ask them about barriers. So we do have some data already from the people we've consulted. And we definitely indeed are looking at a model of implementation. Shawn Marshall is going to be heading up the implementation group. I don't know, Shawn, we don't really have our final implementation plan yet, but I'll hand it over to Shawn if you wanted to have any insights into that question.
Sure. I think that's a really important point. Will we be doing it? Yes, we will, because in fact, I think one of the important elements of implementation is just as we've learned from the guidelines from different guidelines, and then use that to inform to make our guidelines. So, for instance, building upon it, implementation, looking at barriers and facilitators needs to be, that information needs to be carried forward. The interesting thing about implementation, though, also is it's also done at the grassroots ground level. While you can try and implement across the province, the knowledge to adaptation cycle is actually created the local site in mind, because your barriers, and that was why you're asking questions about even what would help this get implemented. Your barriers are often local. So, for instance, managers are barriers, and managers are different across different sites because of their, and managers are barriers. They're also facilitators, of course. So, please don't say I'm being harsh. Your staff, our staffing, all of us are facilitators and barriers, and there's a local environment there. But we can learn as to what things are blocking things from being implemented and what things were successful. So a key point to a successful plan is looking at those barriers and facilitators and cross-fertilizing. So that was part of the plan, yes.
So there was another question which was which is an important question which we had to tackle a little bit when we did the INCOG guidelines, which was, how will standardized tests from a copyright perspective be handled for the website? And will you work with publishers for this? So that's a great question. One of the things that we have tended not to do is particularly when it's specific to one discipline, we will provide guidance to tools that you will use. The biggest example I can come up with is the neuropsychological testing. We believe that it should, again, be a clinical decision somewhat about the tools and the battery you might use. However, we're hoping that for more global outcome measures like the functional independence measure, which we already use, and things like that, they will not have the copyright prohibition. So we're trying to pick tools that are readily available and feasible to use. And one of the challenges we have in this, and it's a great question, because the other challenge is they ideally should be available in French and English, because then we can compare across the provinces in Canada. So you've touched on a very important question that we'll have to tackle. In general, we've tried to make choose tools that do not have proprietary issues and use generally available. So that is a consideration for us as well, and our expert panel. Thanks for that question.
And I can comment further that sometimes there's only a minimal cost when you work with the publisher or the person who holds the copyright on it, and it's worthwhile paying that minimal cost for general accessibility across your guideline, even if it's posted on the web. So in some instances, but I do agree with Mark, for it to be used. For people to have things taken up, cost is a barrier. So again, we have to look at tools that maybe are non-proprietary.
Mark and Shawn, are you able to hear me?
Yeah.
It's Corinne speaking, and I guess I wanted to add to the question about the barriers and facilitators question, and just to let you know that we will be planning the implementation and working with stakeholders to sort of decide what's best for the sites that we're going to try to implement in. And there's a whole process being kind of laid out, and we'll be, once the guideline's a little further along in its almost being finished stage, we will be talking to people about what they want out of the implementation and trying to do a bit of a gap analysis with various stakeholders to determine, okay, so these are the key priorities that we might be able to implement across Ontario and Quebec, but then there might be some individual sites that want to implement something specific that is out of the top most highly prioritized guideline recommendations. So we will be doing a little bit of that, and part of that gap analysis will also look at the facilitators and barriers in the sites that we're going to be trying to work with. So bear with us, but we do have a sort of a draft plan, but it can't be decided until we start working with our stakeholders.
So we have another question from Anne, who's asking a very important question, is will we be reaching out to other sectors like mental health, for instance? And this is an important element of any guideline, as most of the time people aren't even aware of them. And even within the mental health sector, we suspect that they're not, they may not be aware of brain injury guidelines because they're in that sector. So we definitely want to reach out to a large number of sectors. Part of it is just building awareness. And so in the past, when we've done our concussion guidelines, the team members like Shawn and myself have made an effort to disseminate to as many different populations as will listen to us. So that's a great suggestion. And I think what we can all do as ambassadors is when a psychiatrist or a social worker has a patient with dual diagnosis like schizophrenia and brain injury, that we are trying to help people with guidance about what medications might be appropriate and how to manage the concomitant brain injury. It's a challenge, but certainly we're doing our best. And on our panel, we have a number of neuropsychiatrists who have participated in the process and helped us. And so we believe that we are going to be providing guidance. And then, of course, Ontario Neurotrauma has been very active, as many of you know, in the Substance Use and Brain Injury Group, or SUBI, which Carolyn Lemsky and many others have been part of. And we certainly have tried to include some of those tenets of that so that partnership between brain injury and mental health is a little more clear. So great question, and certainly I think it just reminds us we should be reaching out to those who might also benefit from the brain injury knowledge.
All right, do we have any other questions?
I don't see any more questions, nor anybody typing, so.
Yeah. So I just wanted to really thank you, Mark and Shawn. That was a wonderful presentation. Thank you so much for your time. And thank you everyone who participated and everyone who's watching this recording afterwards. If you'd like to subscribe to our webinar series and would like some more information about our webinars and our future work, contact me at the email address on the screen.
Okay. Thanks a lot. We have a couple of, I just want to make sure we're not missing any questions. We have a thank you very much, Penny, and everybody for attending. I think that I know that everybody's got to go back to taking care of real patients and things like that. So just want to say thank you for your attendance, as well as David and Shawn for your help. David in particular was the technical whiz. So if it went well, we can thank him. Thanks a lot.
Thank you, everybody.